Hey folks, Scott Weingart here, and this is an EMCrit We. Today we're going to do a little deep dive on physiology. Now, if you've been a long-time listener to the show, you know I love physiology. During medical school, I was the physiology teaching assistant for the physiology classes. I deep dived in acid-base over the course of my medical school and residency career. That's the area I think I know best amongst physiology, though I love it all. I think the way the human body works is astoundingly beautiful. And I found a partner in crime to do this episode with, Alex Yartsev. Now, I am going to do his intro and gush about his site, Deranged Physiology, in the course of the show when it actually starts. So I'm going to just leave that all off here. I will give you a little context about what this episode actually is. There was a tweeter who was putting out, he had written a textbook of basic critical care, like an intro book, and just was rabble-rousting on Twitter. And, a lot of people are just like, don't poke the troll, just leave him alone. And, I can't do that. So, I engaged a little bit, not enough to, really start a war. But I did not find him particularly open to back and forth. And so I figured I'd just do this podcast. Now, I tried to get Josh on as well, and he's like, look, I don't deal with this crap anymore. I got more important things to do, like writing the pulmonology section of Internet Book of Critical Care, but I did get his feedback as well. This will make a lot more sense if you actually go to the show notes and just look at the tweets. And I'm deliberately not mentioning this guy's name because I'm dealing with the ideas, not the person. He could be the nicest person in the world who just has a poor interaction style on Twitter, but once your ideas are out there, they are free game for anything anyone wants to say about that, or at least that's my viewpoint on how to handle debate in the realm of ideas. So we go for about 30 minutes talking about the physiology of oxygenation, whether you actually need PaO2 from a blood gas or you could use pulse ox, and a lot of the podcast is in response to the tweets that, again, you could see in the show notes for this episode. But you will get something out of it even if you never bothered to look at those tweets, I think. All right, just before we jump in, we still have a few tickets left for Reanimate 9, San Diego, resuscitative ECMO course. Incredible, almost all hands-on. You will learn procedure. Even if you never did ECMO and came to the course, you will be markedly better at central lines and other forms of Seldinger procedural access. I promise. I can make a promise about that. And you will love the course. 2 days, San Diego, November 8th and 9th. If you're interested, reanimateconference.com. That's reanimateconference.com. One word, reanimateconference.com. Okay, let's go to the we. All right, man. So first question is always the same. Who are you and what do you do?
My name is Alex Yartsev. I'm an intensive care specialist at a hospital in Sydney, Australia, and my main role here is to coordinate their education program. And on the side, in the small hours of the morning, I indulge my clearly unmet need for creative writing by writing Deranged Physiology.
Yeah, people, if you don't know about this, need to go check out this website. It is a labor of love. It is beautiful. Its ostensible purpose, and you tell me if this is incorrect, Alex, is for people during their oral boards, but it's a wealth of information far, far beyond that. In fact, why did you start it, and what is the purpose of the site?
Initially, I started this thing because I was having a lot of trouble focusing my ADHD brain on studying for the nightmarish set of exams that are designed to act as a kind of a barrier into entry into independent critical care practice in Australia. And these exams, it took me a long time to pass because I was studying incredibly inefficiently, because the only way I seem to be able to study is by writing a whole textbook chapter about the thing that I was studying about. And the way for me to keep on track and to keep myself accountable was to put them online, because somebody else is reading this, so they have to be high in quality, detailed, and I have to be doing it regularly. So that's how it happened. And then when I finally passed and became an intensive care specialist here, I thought I missed out on doing this for my primary exams, which deal mainly with physiology, pharmacology, and all the basic sciences. I really only made the very basic notes, and maybe I should revisit all of that stuff. And so in 2016 or so, I started doing notes for the basic sciences, which are that is a labor of love, because now, at the time I've grown up, I can spend as long as I want on the pharmacology of some obscure antihypertensive from the 1950s, and I absolutely do.
Oh my God. Yeah, I can't state enough how important it is for people to go look at this site, because I've been looking at it for years and it is absolutely remarkable. But what you've discovered, and I don't know if you actually are just being modest in terms of how you figured this out and decided to do it, but based on learning theory, what you have done is perhaps one of the most valuable ways to actually get mastery level knowledge. Just reading about stuff and using it in your everyday practices, that's pretty workaday. But if you are capable of actually putting it into words that other people can understand, Richard Feynman talks about this extensively. You need to be able to teach it so well that you could teach it to your 6-year-old. And I don't know if my 6-year-old could read Deranged Physiology, but I know it was certainly better explained than most of the textbooks of physiology that I had experienced. So it's really fantastic
You're
work.
so kind to that. Thank you so much, Scott. I've got to say that it's massively flattering to hear you specifically say this. I'm glad. You're quite right. Like, active learning is a really important part of how this worked for me, because it was required for me to take the information, reinterpret it, repurpose it, and put it together in a different way, which aids in the retention of the information. Yeah, you're quite right.
All right, let's distill some of that knowledge. Today, we're going to talk about the physiology of oxygenation primarily, maybe some other stuff thrown in there. And why don't you just give people a little recap of what actually happens in terms of the oxygen cascade from the lungs down to the mitochondria?
Okay, so oxygen cascade basically is a term that we use to describe the stepwise decrease in the partial pressure of oxygen that occurs between the atmospheric gas, which is where all the oxygen typically hangs out, and your mitochondria, which is where it needs to get. The atmospheric air that you inhale ends up being a pH of about 160 or so, and then in the airways, some humidification occurs. So by the time that you reach that isothermic boundary, somewhere around 5 centimeters or so distal to the carena, you end up having some maximum humidification. The oxygen content decreases slightly because there's all this extra water vapor displacing the volume. And then in the alveoli, because of a couple of possible reasons, some CO2 enter the mixture, and that decreases the PO2 further. You've got some alveolar oxygen. Let's say that it's about 100 or so PaO2. And that alveolar oxygen ends up in the capillary blood, which very closely equilibrates with. And then with a little bit of venous admixture from the various veins that empty into that part of the circulation, the PaO2 in the arterial blood drops a little bit, maybe by 8 to 10%. And so then diffusion occurs then from the arterial blood into the tissues, where the partial pressure of oxygen in the tissues is substantially lower. It's somewhere in the order of 30 millimeters of mercury. And in the tissues, obviously not where the oxygen needs to be. It needs to get into the mitochondria inside the cells, which is yet again another diffusion barrier, although very small, because the surface of the cell and the mitochondria are that's a very short distance. But at the same time, there's a lot of them, and there's a lot of space to diffuse through. So as a result, the partial pressure of oxygen in the mitochondria ends up being quite low. It's something like 5 millimeters of mercury. And if it gets anywhere below 1 or 2, typically it's the Pascal point beyond which anaerobic metabolism then begins to take place. That's not mandatory, and a lot of organisms have a hugely increased tolerance for hypoxia. The Pascal point for the mitochondria of mollusks and things are, generally speaking, quite a lot lower than for humans, so they can tolerate oxygen as just like a cofactor in their metabolism, and it can survive virtually anaerobically for prolonged periods. Partial pressure of oxygen in the mitochondria in terms of like parts per million. So for us, however, it is the sort of 1 to 2 millimeters of mercury.
Yeah, it's that last piece that I really wanted to have this actually spoken about on the podcast, because I don't think people understand how low the tension of oxygen actually is at the level of the mitochondria. 5, in an ideal circumstance, you go down to 1 to 2. And that gives so much room for preservation, even in hypoxemic states. You have, the body is just amazing. All of the interface and capability of sustaining through difficult physiology. Okay, well, I'm not going to geek out on how amazing.
Oh, no. So don't even get me started, because apart from this level of redundancy, where the mitochondria is getting supplied with abundant excess of partial pressure of oxygen, you've also got this huge amount of redundancy built into your circulatory system. The amount of hemoglobin you have and the amount of oxygen carriage it's capable of is hugely more than your body needs at any given time, which makes sense. Otherwise, your venous oxygen saturation would be 0. Yeah, there's just all these extra layers of safety built in. And you're right, we could go on about this. Let's focus. What are we talking about?
Okay, before you find out what we're really talking about, I just want to say in the show notes is an image for what Alex just described, as well as many other images that will make this make a lot more sense. So if you're curious to actually see the visuals that go with this audio, just come on over to the episode link for this Okay, before one more piece of the physiology, because the oxygen cascade in and of itself doesn't really represent the carriage of oxygen, because it's not just dissolved oxygen that the cascade might make you think. But anyone who knows their physiology knows there's this huge reservoir of oxygen being actually carried by your hemoglobin. And how do you add to the oxygen cascade to make people appreciate the role hemoglobin is actually playing in all this, Alex?
This is really interesting. So the amount of oxygen dissolved in the water of the blood and the blood cells is actually minimal. So it's 0.03 mils per millimeter of oxygen, which is very little, considering that normally, let's say that your PaO2 is 100, so that would be just 3 mils per liter of extra oxygen. Whereas at the same time, if your hemoglobin is 100, then that hemoglobin is probably carrying about 135 or so mils of oxygen on that. It's a huge, massive contribution from the hemoglobin carrying of oxygen and the minimal contribution from the dissolved oxygen. Of course, this can be changed in weird circumstances. Let's say that you're critically anemic and you have a hemoglobin of 60, and the total carriage of oxygen by that is like 80 mils. And then for whatever reason, your intensive care specialist has put you on 100% FiO2. So you're now carrying as much oxygen as possible dissolved in your bloodstream, which is probably about 20 mils. So in that scenario, of the total oxygen contribution, of the total oxygen carriage, the dissolved oxygen is giving you about 20%. That's a fairly unique scenario, not quite as unique as, for example, hyperbaric oxygen chambers, where theoretically you could have almost all, in fact, completely all of your oxygenation supplied totally by diffusion at a partial pressure that is massively high, in which case you don't actually need hemoglobin in your circulation at all. But we never see this for any reason. So it's probably pointless to mention.
Okay. Now, the main purpose for getting you and your expertise on the podcast was there is a set of tweets that I actually have reproduced in the show notes for this episode. So folks could go at their leisure and actually see all these. We're going to explain them so you don't have to, while we're actually doing the episode, go to the show notes. But at some point, it'll probably be utile for you as a listener to do. But there was a contention that oxygen saturation, especially as reported by a pulse oximeter, is inadequate to many of the tasks of critical care. Now, I get ABGs occasionally, but for the most part, I'm able to take care of my patients with VBGs for pH and CO2 and oxygen sat through a pulse ox. And so we're going to investigate, Alex, some of the commonalities in yours and my practice, and maybe some of the areas we may disagree with this original tweeter. Maybe we disagree with each other. We'll see. But I guess the first question along those lines is an ABG useful, and when do you get them to assess the cause or severity of lung disorders?
So it's really interesting. You would probably be able to get a reasonable approximation of most things from a venous gas that you'd be interested in. And the specific situation where you would need to get a PaO2, if you're specifically looking at the PaO2 and you need that from an arterial blood gas, there's not that many situations where you would need it. One such situation is to very accurately assess the diffusion in the context of, for example, assessing that lung for suitability for donation. Another one would be where you are trying to see whether the patient will qualify for a home oxygen, which requires certain room air PaO2 targets to be met, which is probably like just a very ancient set of rules that we have locally here in Australia. But we find ourselves having to do room air arterial blood gases in order for the patient to qualify for some sponsored home oxygen devices. There are scenarios clinically where you might need to have an arterial gas because you're trying to assess the arteriovenous difference in some parameter, like, for example, CO2 as a means of determining the efficacy of your circulation. If you're looking at the veno-arterial CO2 difference. Those are scenarios where you need an ABG. But realistically, under most circumstances, the difference between arterial and venous blood is so small that you could absolutely make do with venous gases, and I do.
Now, the main point that this tweeter was making is that PaO2 is essential for critical care. One of the situations I think we may actually want to get a PaO2 is in a patient we're assessing for degree of severity of ARDS. Now, even for that, there is recent literature, and some even not so recent literature, saying that the SF ratio, the saturation to FiO2, may be as good as the PDAF ratio for things like this, or even for things like SOFA scoring. What's your take, Alex? What are you doing? Are you actually, let's say you had a patient with really bad lungs and you wanted to assess how bad they really are. Are you using the saturation, or in those cases, are you getting an ABG?
That's really interesting. I think the tendency locally, and I don't know what it's like in the US, but what we do here around these parts is that we typically use more, we don't usually use a PF ratio to make decisions about the care of ARDS patients. We note them, we debate whether or not somebody is hypoxic enough to merit prone ventilation in a scenario where prone ventilation is contentious. There's something else wrong with them that makes it a relative contraindication, like the pregnancy, morbid levies, something like that. So we typically don't use the PF ratio very much in our decision making, but I get what you're saying is that if, for example, you were to use PF ratios, for example, for research purposes, to stratify the risk of a large group of patients, then would the SF ratio be sufficient? And my take on it is yes, it would, because that would greatly decrease your dependence on arterial invasive monitoring, for example, and you'd be able to enroll different patients into it. And the groups that you'd have to exclude would be ones that are very uncommon in the ICU. For example, patients with carbon monoxide poisoning or methemoglobinemia or things that are incredibly rare here because we don't have a lot of patients on dapsone and pentamidine and other things. So we typically don't see a lot of those dyshemoglobins in our community. And it would probably be quite safe to say that the pulse oximetry and the measured ABG oximetry are very similar. So I probably would support the use of SF ratios for sure.
Yeah, I think I probably agree with you. All right, so if we're not using it very often to assess for degree of lung injury, the second possibility, and this was, I think, the contention of the tweeter, was that you actually need an ABG, or specifically, when we say ABG, what we mean is PaO2 to assess tissue oxygenation. And I don't know. I think for me, pulse ox is a better representation of tissue oxygenation. In fact, the stuff that's always running through my head when I'm wearing my intensivist hat is the DO2 equation. Maybe you could talk a little bit about that equation, Alex, and then say what your practice is to assess the best marker of tissue oxygenation.
So the whole point of the circulatory and respiratory systems really is to get oxygen to the mitochondria and the cells. And the way that oxygen gets there, as we already said, is mainly not in a dissolved form. It's mainly getting there in the form of being carried by hemoglobin, which means that the amount of oxygen attached to hemoglobins and the amount of oxygen in the whole blood that you're pushing to the cells is probably a really important parameter. Basically, that DO2 equation describes the amount of oxygen per minute being delivered via whole blood. And that is cardiac output multiplied by the total oxygen carriage of the blood, into which you factor the concentration of the hemoglobin and the maximum oxygen carrying capacity of the hemoglobin, and to a lesser extent, the partial pressure of oxygen that's dissolved in the blood. Of those, under normal circumstances where the patient is not desperately anemic and hyperoxic, the hemoglobin contributes the vast majority. And it is the saturation of the hemoglobin, how much oxygen is bound to that hemoglobin, is the thing that determines that oxygen, the content of whole blood the most. So on that basis, I would have thought that the oxygen saturation of hemoglobin is the more important determinant.
Yeah, that's what made sense to me. And I'm not even sure what PaO2 tells you at this point, because so much is going to depend on your patient's concentration of hemoglobin, their cardiac output, and then your oxygen sat. And PaO2 plays very little role in it. And I guess if we gave them the benefit of the doubt, we could say that PaO2 may give you a representation of the patient's lungs somewhat that may allow you to anticipate their future course. I'm really struggling here to figure it out because it's so foreign to my...
to stretch this. Yeah.
Yeah.
So it feels maybe, okay, so to be the devil's advocate, you could say that the saturation of hemoglobin is to an extent determined by the partial pressure of oxygen as well as by a bunch of other parameters. And on that basis, you can say that PaO2 is important if you were, for whatever reason, extremely suspicious of your oxygen saturation monitoring equipment. If you're in a scenario where something is interfering with your pulse oximetry measure, let's say you've given your patient tons of methylene blue and their SATS probe measures 80%. Okay, in that scenario, you become dependent on the measured arterial saturation of hemoglobin that the ABG machine will be able to give you, or a co-oximeter if you have one of those.
Absolutely. Absolutely. Now, this is a slight tangent, but I can't help myself. You know what's not made clear by the DO2 equation? It's in there, but I don't think people appreciate it enough. It's like the natural question you would get from someone who is inexperienced at critical care is, why don't we just push the hemoglobin up to 16 in this case, or 18, and get even more ability to deliver oxygen? And let's even absolve the possible horrible effects of other people's blood going through your system. Let's say we have a perfect artificial hemoglobin. Even in that case, you wouldn't want to do it, Alex. Why would you not want to do that?
there's things that, so a couple of things that happen when you increase somebody's hematocrit abnormally, and not all of those are the positive. So I think that there's ways to increase the oxygen carriage in the blood. Correct. There is already a substantial amount of buffering, however, that happens at the cardiac output multiplier of the DO2 equation that will by far outstrip anything that the concentration of hemoglobin can potentially achieve. So I'll give you an example. The lowest hemoglobin concentration that was recorded in any surviving human being was about 10 grams per liter. That's 1 gram per deciliter for Americans. And that's incredibly low. It was a guy who had paroxysmal nocturnal hemoglobinuria. It was found collapsed on the floor of his apartment with a lactate of 20. And my favorite part of that case report is that they gave him just 1 unit of packed red cells, got his hemoglobin up to 2 grams per deciliter, and his lactate dropped to normal. So he just needed that much because he was a young 30-year-old dude, and his circulation was working beautifully. He was able to deliver enough oxygen to his cells to not be in anaerobic metabolism. And all that required was a high cardiac output. It was probably higher than normal by a factor of 4. But still, that's what you really need in that scenario. If there's not many scenarios where you would justifiably be able to increase your hematocrit by a factor of 4 to achieve the same result. And that's probably the point that should be made.
Yeah, and I'll go a step further and say that the viscosity of the elevated hemoglobin actually steals from your cardiac output to the point where it's not actually beneficial. And we see this in 100%. ECMO patients. If you, why not just prop their hemoglobin up to normal? Let's put them up to 15, and you could watch the flow actually go down on your pump because it's a much more viscous blood. The balance seems to be at the same kind of place we've wound up in intensive care. 7 to 10 is a really nice place to have a nice balance of oxygen carrying capacity while also having low viscosity blood that allows for a good cardiac output. One of the things I always taught in physiology to get people to be able to conceptualize this is that PO2 builds the oxygen saturation, and then the oxygen saturation actually is what supplies the tissues, harkening back to that DO2 equation. Is that a fair statement, Alex? Does that ring true with you?
Yeah, I would agree with that. That's exactly what PaO2 does build the SAT, and it collaborates with the pH, the 2,3-DPG, the various sort of influences on the oxygen hemoglobin dissociation curve to build the saturation. And then it is the saturation that does all of the work of oxygen delivery, in my humble.
Yep, totally agree. All right, here's a side question. And so we know pulse ox, hopefully people understand the basic rudiments of that. And we know the portable blood gas machines are not measuring the SaO2, the SaO2. They are just calculating it based on the other parameters they actually do measure. They measure pH, they measure PaCO2, they measure PaO2, and then calculate the SAT. And we know co-oximetry does measure it. If you run a blood gas on a machine that is capable of co-oximetry, but you didn't actually order co-oximetry panel, is it measuring it or is it calculating it? Do you know the answer to this, Alex?
A little bit, yes. We happen to own both kinds of devices where I work. And there are point of care devices which are small, which take a small amount of blood. Like you can even put a pediatric capillary sample in there, and they will do this by calculating. So they will get a pH and a CO2, and from that, they can extrapolate your oxygen saturation on the basis of basically just a lookup table that's in the machine. And that's a legitimate way of doing it because most of the time they'll probably be correct. Co-oximetry is by far the more accurate. So the, big, proper, non-portable ABG machines will take your red cells, blast them with some ultrasound to break them down so the hemoglobin becomes free, and then watch them past a sensor that shines light through them at about 200 different wavelengths and creates this beautiful representation of the various absorption spectra of the hemoglobin species, and then uses the Lambert-Beer law to calculate the concentration of those species. And that is probably the most accurate way of determining exactly what kind of hemoglobins you've got in there. And fortunately, all of them have spectacularly different absorption patterns, which means that you can tell exactly how much carboxyhemoglobin, deoxyhemoglobin, how much sulfhemoglobin, nitrosyl hemoglobin you've got in there, which not normally get measured by the ABG machines because they're not particularly relevant. But the point is that dyshemoglobins get measured much more accurately. And that's the SaO2 that you can probably trust if you're feeling like your point of care devices that are portable are not giving you the right answers.
So if you're running it on a big machine, even if you're not requesting a co-oximetry panel, it is still actually measuring.
Co-oximetry. Yeah, that's correct. And it is usually set up to report at least the carboxyhemoglobin and the methemoglobin because those are the
No,
clinically.
you must be used to the Australian system. In America,
Uh,
they never report it because they want you to
right,
actually order it separately if you want it to have a separate billing
right.
code. But, and
Okay.
this to speak to what you just said, because it's such a valid point, as far as I know, every lab I've spoken to, they actually can give you those numbers without another sample. The machine has it. They just don't
Yes.
put it on the lab report.
Oh my
And
goodness.
so if you ever want those numbers, call your hospital's ABG lab, and not for you, Alex, because they're reporting it for you. But if you need a CO or a methemoglobin, say, hey, do I need to send you another sample, or could I just put the order in and you tell me, and you run it from the sample you've already had? Because the machine in general does do the co-oximetry. It just doesn't put it up on the screen in most of the US.
Yeah, right. There you go. I was not aware of that. And that's, I feel slightly privileged.
You have many privileges down where you are compared to our country, but not the least of which is better coffee. But be that as it may. All right. So then we'll go into the actual tweets that we heard from this intensive care doctor. And the first one is a case where I think he actually has a valid point. And this was a patient who was initially admitted with obesity hypoventilation syndrome, aka Pickwickian. He had some atelectasis and he had some possibly a chronic PE. And his AA gradient was quite high, A gradient of 94. His saturation was a little bit low at 89%. And he shows the images of the patient's lungs and it doesn't look pristine. And then he had this patient 4 days later, and the patient still had a SAT of 89%. And they called pulmonary to evaluate what's going on here. And they actually, pulmonary in this case, asked for a room air ABG, and the room air ABG showed an elevated PaCO2 and no AA gradient at all, basically what is normal, 13 millimeters, insignificant AA gradient. And they said, now we could conclude what's going on is purely hypoventilation, and we wouldn't have known that without an ABG. Now, what are your thoughts on this case, Alex?
Well, it's really interesting. So the ABG would have given you the CO2 in this scenario, which would have been probably really important from lots of reasons, among them this calculation of the alveolar gas equation to tell you whether or not hypoventilation is the reason for the hypoxia. So to demonstrate that the hypoventilation is the reason for the hypoxia is the key issue here, I think. And under some circumstances, you would need an ABG to be able to prove that. For example, there may be some jurisdictions where that's actually a legal requirement for the patient to qualify for some kind of a state-supported home CPAP or home oxygen device. Whereas clinically, though, I think a lot of this could have been arrived at by examining the patient, taking a history, and from observing their episodes of apnea while they're undergoing continuous pulse oximetry, which absolutely would have been enough for me to put them in that Pickwickian diagnostic category.
Yep. All right. Fair. Now, I'm going to go to another tangent, but I've just wanted to have a space to actually talk about this on the podcast for a while, and it never quite fit in. I hear from many physicians and people I speak to about the physiology of oxygenation that when a patient's breathing room air, the reason they drop their oxygen saturation and their PaO2 when they're hypoventilating is because of the increase in carbon dioxide. In fact, that was what was taught to me during my physiology training during medical school. The CO2 goes up and that causes the oxygen to go down. Then I was speaking to a intensivist and physiologist down in your neck of the woods, David Story, brilliant physiologist. And he actually said, no, that's not it. The CO2 in the alveolar gas equation is just there to represent the patient's minute ventilation, not to actually be the cause of the oxygen going down. And I actually put the paper, it's probably a bit much to call it a paper, it's a letter to the editor, it's just one page, but it's Dr. Story's contention that no, the CO2 is a marker, it's not the actual cause. How does this hit you, Alex?
Look, I think that it's an absolutely valid way of looking at it because the two are inextricably linked, and it's really just an academic point of view to debate whether, like the gas equations, are the laws of physics that dictate what the content of the gas mixture is in relationship to its pressure. That's pretty well fixed in physics. But at the same time, when we start talking about what is the cause of what and what is an appropriate representation of what, that is an absolutely valid view to take, and I would support that. I'm surprised that I haven't read that letter because it sounds like something I should have come across.
Yeah, I'll send it to you after the show. And if anyone out there wants to do this experiment, I think it would be easily proven, is you just have to give like exogenous carbon dioxide to a patient who's paralyzed on the vent. You drop them down to room air And you actually see, since, they're you do a pre and a post, and you see that, I think, if this is true, that even though their minute ventilation stayed exactly the same, their CO2 had elevated from the exogenous CO2. Did the PaO2 drop from the pre and post? I think that would prove it one way or another. So here you go. Anyone who is in an ICU or in anesthesia, please do this experiment and prove Dave's story right.
Yeah. Sounds like I'm going to have to hire some unsuspecting medical students for some unethical experiments.
Unsuspecting medical students are the fodder for all good experiments.
Correct.
All right. The next image from that same tweet actually has a patient with a profound alkalemia. Their pH is 7.6 in this case. What's the highest pH you've ever seen, Alex?
Probably 7.66, and a dude who was a non-English speaking transplant donor of a kidney who was given a PCA button, patient-controlled analgesia button, with some fentanyl hooked up, but just was not explained how to use it in his language. And he hyperventilated so profoundly that I attended a emergency response for him for quote-unquote seizures, which were in fact just hypocalcemic tetany from the alkalosis. That's the most terrifying situation ever. And we were able to fix it very quickly. But that's probably the highest CO2. He was a fit young guy, so that's why he was able to ventilate like that.
Wow. That is fantastic.
That is a crazy story.
All right. So this patient with the pH of 7.6 has an oxygen saturation of 93% and a PaO2 of 50. And the contention by the tweeter is that without an ABG, now I will state, you need to know this patient's pH. So I agree, you needed something, but it could have easily been a VBG. So let's say you knew the patient's pH, but he's saying without the PaO2 from an ABG, you would not understand this patient's oxygen physiology and would mismanage the patient. He's saying this patient needs immediate response, immediate efforts to increase the patient's PaO2. And I would say if we had the exact same scenario, same patient with a 7.6 pH with a PaO2 of 63, by the tweeter's logic, that patient would be fine. He has a ironclad cutoff of a PaO2 of 60. That patient would be in just as much danger of poor tissue oxygenation at a PaO2 of 63 and a SAT of 96%. Because the take home is not the PaO2 tells you the answer. The take home is you must, as an intensivist, understand that there is going to be a left shift of the oxyhemoglobin dissociation curve. And as a result, even relatively good-looking SATs are going to be much more dangerous. And if the patient has any alterations of their hemoglobin concentration or their cardiac output, they're in really hot water. And that's the take home. It's not get an ABG if a patient has profound alkalemia. The take home is these patients are at risk of poor oxygen delivery to their tissues because there's going to be a much more, the hemoglobin's going to hold on to that oxygen with far more avidity. Am I getting anything wrong there, Alex?
No, you're absolutely correct there, and you're not getting an accurate impression from the ABG either. So you get if you don't know that this is happening, the ABG will not tell you that the delivery of oxygen to the tissue is going to be impaired because the hemoglobin and the oxygen are binding so avidly together that they're not being released at the level of the capillary. The ABG is not going to really tell you that. The PaO2 is also not going to really be illustrated there. The key issue that this demonstrates is that you actually need to be aware that this is happening because you understand how the oxygen hemoglobin dissociation curve works. That's basically what I think is the take-home message here, is that you kind of need to be aware of this factor and of what effects pH has on the release of oxygen peripherally.
Absolutely. Now, he goes further and actually draws an arrow to that same patient who, if their pH suddenly went from 7.6 to 7.2, would drop their oxygen saturation from 93% to 77% with no change in their PaO2, which is also true. But I think, first of all, the patient has much bigger problems if their pH drops from 7.6 to 7.2. That's problematic to me in the first place. That as that's happening, you're going to see the sats drop. You're going to actually take action at that point. I'm not sure what the point is of what this is proving to us about. You wouldn't even have time in that case to get an ABG in betwixt. So I'm not sure here how an ABG helps either. I think you should probably try to reconcile how this patient dropped from 7.6 to 7.2 more than anything else.
Yes. Taking this completely out of its clinical context is the only way that you can make this look reasonable, right? Because you're patiently watching the pH drop to 7.2 and you're observing a patient with SATs of 77. I think that only as a thought experiment is this a plausible idea. And you're absolutely right. Like the patient would have a lot of other problems, and there'd be no way that this would ever be tolerated for any sustained period of time. So the ABG then becomes completely pointless. You're quite right.
Yep. All right. His second tweet, because there are a lot of them, and look, I don't mean to bag on this gentleman. I don't know him. He might be very nice. His Twitter persona is not particularly nice, but I've often met people in real life who I look on Twitter. Most of them are anesthesiologists, unfortunately, Alex, and they are just viciously cruel on Twitter. And then I meet them in person and drink a beer with them. They're the nicest people in the world. I think there's just something about the personality of anesthesia that leads to a very snarky and somewhat mean persona on Twitter. Do you have any insight into this? Why are anesthesiologists so mean on Twitter, Alex?
They're delightful people in general, and in person, I agree, beer is usually not even required to make them pleasant. But in the context of look, I think it's the wonderful effect that Twitter has on generally people, broadly speaking, and some of those people happen to be anesthesiologists, and it is the combination of anonymity and a wide platform that really just gives that extra zing to all the random things you say. And if you say random things that are contentious and raise eyebrows and make people angry, then they will just reinforce that by liking it and retweeting it. And it's just this wonderful environment that promotes toxicity. I do love it so much that I even joined Twitter at some point and have neglected my account for about 6 months. You might have
You're
noticed.
probably wise. I think it's to the best of your mental well-being. All right. So he put out another tweet because people started continuing to bait him, and it was enjoyable to watch. 3 reasons it's ridiculous to say SpO2 beats ABG. Now, just as a side, no one ever in any conversation had with him on Twitter said that it beats ABG, as in don't get ABGs. There's a place for every test in medicine. People's attempt to get across is that most of critical care management is done with pulse ox, oxygen saturation. That's all everyone was trying to say. And when I tried to narrow him down on, so are you saying we shouldn't use the pulse ox? He's like, no, of course you use the pulse ox. And then I'm throwing my hands up. I don't quite know what you're saying. But then he never truly clarified. But he said 3 things. And to give him the benefit of the doubt, some of these have some truth to them. So we'll go through them one by one. SpO2 estimates SaO2 often poorly. What do you think about that one, Alex?
Okay, they're so close to each other under most circumstances that it is absolutely reasonable to use one continuous and inexpensive method as a surrogate for the other intermittent expensive method. And the situation in which you would break down that relationship between SpO2 and SaO2 is basically just where you have lots of abnormal hemoglobin species that confuse the pulse oximeter. So if you have carboxyhemoglobin, if you have methemoglobin, that would make your measurement inaccurate. And there's a few other random niche situations where the pulse oximeter, for example, is exposed to light at just the right wavelength to make it confused, like fluorescent lights from old hospitals that didn't use LEDs, but would sometimes do this sort of thing. So there are scenarios which most people who use pulse oximetry in critical care would usually be aware of those limitations and be able to adjust for them and to be aware of them.
Absolutely. And we'll put out melanin as well, at least for every company except Massimo.
100%.
Is problematic at this point.
Yeah.
And I actually have a paper showing that hypotension, not even profound hypotension. This paper actually said blood pressure is at 60, even 65 in some of the patients in this paper. There were inaccuracies, and not the way you'd expect. Most people, and myself included, would have had the intuition that it would actually give us a falsely low pulse ox, because we see this all the time in malperfusion states. It's actually the opposite. It overestimated. Just be wary, I guess, in patients who are, this one was looking at mild hypotension. I'd say in profound hypotension, be very reluctant to trust the pulse ox unless you have a pristine waveform and maybe have validated it at some point during the patient's course with that hypotension that it's actually marking. Because I more and more feel that perfusion may eliminate some of the accuracy of the pulse ox more than we may appreciate. Because the machines,
that is an excellent point.
Yeah, the machines auto wave, they auto adjust the parameters of the wave. So the wave looks good even when there is poor perfusion on some of the machines. And you actually have to look at a perfusion index to know. I think it would be better if we actually had crappy waveforms when there is poor perfusion. It would tell us what we want, which is maybe this is not to be trusted.
Absolutely. That would give you a really clear visual representation that things are terrible. And I'd prefer that as opposed to having the machine automatically set up the waveform to look pretty for you.
Yep. Agreed. All right. Part 2 of his tweet is SaO2 is the product of PaO2 and pH, yet pH is tightly regulated, not in relation to O2. So it can't be the true goal of O2 treatment. Now, this is what we've discussed this before. I don't think PaO2 helps you here either. If you don't understand what acidosis or alkalosis does to the patient's oxygen delivery in either direction, then the ABG doesn't help you for that. So what do you think about this one, Alex?
Look, 100%. I don't really think that you can say that just because, so I really have difficulty finding what the point of that statement is. So yes, you can't have, I guess, a oxygen saturation without some pH helping the oxygen and hemoglobin binding. So I guess that's the point, is that, or perhaps he's saying that the oxygen and the pH are regulated by different territories, by different mechanisms. And so as the result of that, you're targeting oxygen saturation without also influencing the pH is somehow wrong. I misunderstood this.
I don't understand either. And we'll harken back to what we were saying, which is whatever in PaO2 is not what the tissues are going to be seeing. The saturation is representative of that. And whether the oxyhemoglobin curve is shifted or not, it's still the saturation. The PaO2 gets burned through almost instantaneously, and then it's the saturation reservoirs that are the supply of oxygen to your tissues. Even the brain tissues, as we'll discuss in this last point in this tweet, your brain, let's just do this and then I'll make my point. The brain senses and protects a PaO2 of 60. Now, I don't know why that's an argument for getting ABGs, but maybe you can have some insight, Alex.
It is odd. And the brain senses and protects oxygenation by surrogate mechanisms. And there are peripheral chemoreceptors that detect partial pressure of oxygen. Yes, okay, that's fair. And the brain will act on those. And at a certain low PaO2, you will have an increase in the respiratory drive, which I think this is what is alluding to. So I guess you'd probably say that's accurate in a sense. At the same time, though, your oxygen saturation would certainly be changing in this context. So you would be able to use that as a surrogate marker of this reasonably confidently. And in scenarios where other things are affected, for example, where the pH is ridiculously high or ridiculously low, that in itself would be a much stronger stimulus to the respiratory drive than the oxygenation would be. So I think in that scenario, it would be the pH driving and the PaO2 in the passenger seat.
Absolutely. And even brain tissue is predominantly supplied by the reservoir given by saturation. And then I guess the last tweet is the one that just really irked me the most, because I'll actually read what he wrote here. SaO2 folks, I guess that's us, can't have an absolute hemoglobin sat that is adequate. It always, I'm doing air quotes here, you can't see me, but that's what I'm doing. It always depends, because sat is an integrated measure and pH is not regulated by O2. I'd be bummed if I asked my doctor if my oxygen level was okay and they said, it depends. Now I responded, there's the rub. Saying it depends is the mark of an expert on any topic. It is naivete to believe that any complex area could be reduced to absolutes. And further, I hope you understand that nobody who has disagreed with you on this thread believes we should never get ABGs. That was me finally losing it, and he got probably justifiably upset with that tweet. Alex, am I wrong? Do experts have absolutes on everything they deal with in the course of critical care?
I think it's important the reason why somebody gets called an expert is because they don't immediately come back with a black or white answer, but because they weigh things in a way that is deliberate and because they recognize nuance. So I think that's probably the way that I would respond to this. There's probably no reason to say that just because somebody is able to see all the possible factors that influence oxygen saturation, that doesn't make them worse somehow. In fact, I think that makes them better because they recognize all of the things that we just talked about, like the influence of the alkalosis on oxygen saturation. What would happen if suddenly the acid base was corrected?
Absolutely. Alex, what questions should I have asked you about all of this that I've been remiss in not asking?
I think that we've gone through pretty much everything as much as possible. My only regret is that I was not able to pepper the discussion with quite as many ridiculous physiology anecdotes as I typically am prone to.
That just means we have to bring you back again.
That would be awesome, Scott. That's fantastic.
I can't thank you enough for your time, and I'm sure the listeners will agree.
Scott, thank you very much for your time. That's excellent.